Hi, everybody. It's Susan Thornton with the Cutaneous Lymphoma Foundation, and welcome to our July edition of Facebook Live. And thank you to everyone for your patience while we worked out a few technical difficulties in getting the live stream going. So tonight we have with us Dr. Jennifer DeSimone, who is the Director of Cutaneous Lymphoma and High-Risk Skin Disease at the Inova, and I'll try to get this right, Melanoma and Skin Cancer Center in Virginia. Welcome, Dr. DeSimone. Thanks for joining us.
Hi, Susan. Thank you very much for inviting me. I'm happy to be here.
Yes, and for those of you who may have joined us at our two-day program in Bethesda last month, Dr. DeSimone hosted a breakout session, which we did not stream live, and so we thought we would invite her to share a condensed version of that presentation that she did tonight. So she will be talking about the more advanced versions of cutaneous lymphomas and the therapies. And our format tonight will be a little bit different than it usually is, in that it'll be more presentation from Dr. DeSimone, and then we'll save questions for the end of the program. So write your questions down and you can put them in the chat, and we'll open it up to the Q&A towards the end of the program. So without further ado, I know there's a lot to talk about. I'm going to turn it over to Dr. DeSimone, who's going to define advanced cutaneous lymphoma. What does that mean? A brief overview of the etiology. Where does it come from? How does this happen? And in depth, we'll spend most of our time talking about the therapeutic options for more advanced disease, and then a summary, and as I said, we'll open it up to Q&A at the end. So I'm going to turn it over to Dr. DeSimone to take it from here.
Thank you again, Susan. So I'm going to jump right in so that we can save time for questions. First of all, advanced CTCL is defined as stage 2B and higher disease. This includes Sézary syndrome, it includes large cell transformed MF, and it includes aggressive subtypes of MF. So here's the staging system here, and you see highlighted in blue the more advanced stages of disease, and this is what we're going to be focusing on today. Additionally, when you look at the classification system, we'll be talking about classic MF as it progresses to involve lymph nodes and blood and in the tumor stage, and then also we'll be talking about some of the more aggressive subtypes of MF. So quickly, a few clinical examples. What does this look like on the skin? This is a patient with patch stage disease. This is a patient with follicular plaques. Here we see an example of widespread tumors. This is a patient with erythroderma, which is defined as greater than 85% of the skin being involved with skin lesions. And this is the classic triad that defines Sézary, which includes a large burden of abnormal lymphocytes in the bloodstream, obvious lymphadenopathy or lymphatic involvement, and erythroderma, which means that the skin is bright red from head to toe. So the most common question I get from patients is, where did this disease come from? This is something most people have never heard of, and they really want to know, what did I do to get this? Are there any risk factors that I might be passing on to my children, etc.? And so I want to back up and just quickly talk about the healthy immune physiology state in the skin. So in the skin, we have a huge component of our immune system that is active at all times, and T lymphocytes are a big part of that. The T lymphocytes basically lie in wait for any type of pathogen to try to gain entry into the skin, and then those T lymphocytes get stimulated and interact with the greater immune system in the lymph nodes and in the bloodstream to launch an immune attack and to clear any potential infectious organisms from the skin. Additionally, T lymphocytes will sort of monitor for cells that have become abnormal or are trending toward becoming malignant and program those cells to die so that they don't have a chance to proliferate and grow into malignant clones. For whatever reason, in cutaneous T-cell lymphoma, those T lymphocytes become erroneously stimulated or overstimulated. They start to sustain some mutations or become abnormal, and then they proliferate in a sort of unchecked, very rapid fashion. So there have been several theories that have been advanced trying to help us understand why this happens. And I like this slide because it sort of shows all of the things that have been suggested as being causative in CTCL. It's been suggested that viral exposure may sort of overstimulate those T cells, that certain bacterial contaminants may cause this phenomenon, super antigens, autoantigens, CLA effector cells, chemokines, which refers to usually pro-inflammatory natural chemicals that are part of our immune system. Those may become disproportionate, and you may have a pro-inflammatory state emerge. And then I think it is important to talk about Th1 versus Th2. These are sort of the basic functionalities of the immune system in the context of our discussion. And Th1 is responsible for clearing viruses and for surveilling for and eradicating cancers. Th2 is more of an infectious functionality. And in the advanced CTCL state, you have suppression of Th1. So all of your anti-malignant chemokines and your anti-malignant functionality in the immune system is sort of dampened, and you have this prevailing Th2 profile. So these are some of the things that become dysregulated. So again, how does this happen? Well, I think epigenetic mechanisms are definitely in play here. And what that refers to is kind of the combination of genetic susceptibility, or things that may happen in development and the genes that you inherit, environmental chemical exposure, exposure to various pharmaceuticals in the course of one's lifetime, aging, of course, that impacts how our immune system functions, and potentially diet. And so what happens is you start to get dysregulation of cellular cycling. And this is an incredibly complex system, but to try and make it more generalized, you get some kind of bad cocktail or combination of exposures that result in abnormal cellular regulation and abnormal cellular cycling. So no specific causal viral association has been proven, and also there's no one specific gene mutation among all patients with CTCL. There are no chromosomal abnormalities that have been specific either. So this is still a big question mark, and ongoing research should be aimed at trying to really drill down on what it is that may be contributing to CTCL, so that we can, in an intelligent, educated, and specific way, start to avoid things that may be potentially oncogenic. All right, now the bulk of our talk is going to be based on treatment. I'm excited that in the last 5 years, we've developed a bunch of drugs that have been very useful in treating advanced stages of CTCL, and I look forward to kind of giving you some more information about how those drugs work, who they're appropriate for, their side effects, etc. But the basic overview I like to start with is this great illustration. And what you're looking at here up top is stages of disease, so from very early limited 1A disease going all the way up to 4B, and then you start to see where the various categories of therapy come in as being useful and appropriate. You can see early on we use skin-directed therapies. Those are things that are treating the disease from the outside. There's a lot of cross-coverage where radiation may be appropriate, various types of radiation. And then as you get into more advanced stages of disease where you've got tumors, you've got bloodborne disease, you've got lymphatic involvement, that's when we really start to rely on systemic therapies, multi-agent chemotherapies, maybe even entrance into a clinical trial. And then also extracorporeal photopheresis may be appropriate as well. So I think it's important to think about where you've got disease when you start to think about what kind of therapy you might need. So Dr. Kupper and Dr. Clark up at Dana-Farber found out that there basically is a separation between which cells are involved in various types of CTCL. There are the tissue resident memory T cells that really live in the skin with minimal circulation internally. And so if you've got disease there, you've usually got classic MF, and a skin-directed therapy is going to be required, or therapy with an agent that you know has good efficacy or penetration into the skin, versus blood involvement by central memory T cells, which usually is seen in Sézary syndrome. Those cells really are locked in the peripheral circulation, very little movement up into the skin. So a skin-directed therapy would not be appropriate there. So this, again, is just kind of laying the groundwork to help you get a general understanding of why we choose certain drugs. We want to think about where a patient has disease and then choose drugs or therapies that we know have activity in the appropriate compartment or compartments. So skin-directed therapy, as I indicated, is really most appropriate as monotherapy for early stage disease, but you can use it as a component of combination therapy, in conjunction with some systemic therapies to adequately address all compartments that might be involved. So now we'll switch gears a little bit and focus on radiation oncology. The first type of therapy I'll talk about is called low-dose brachytherapy, and this is pretty cool. There's good evidence supporting this. The way that it's performed is by making a customized facial mold, usually face, but it can be on other surfaces as well. Typically, it's most applicable to the face because you've got very convoluted, convex, multidimensional structures, and so you need a customized mold. And then the software and the equipment allows the radiation doctors to provide a very light, almost dusting of radiation, and they can control how deeply it penetrates the skin, keep it very superficial so that you're not sustaining damage to the deeper tissues and you're getting therapy right where you need it. There's great data, as I mentioned. One study that looked at 23 lesions found that just 2 doses of radiation at 4 gray, which trust me is a tiny, tiny dose, resulted in an overall response rate of 100%. Other studies have shown that similar doses of radiation resulted in a complete response rate, that means totally gone, of 92%. So this is very effective. More traditional types of radiation therapy are called electron beam therapy. So this is generally useful for big, thick tumors. Typically, it's provided in a series of 10 to 20 sessions over the course of 3 to 4 weeks. And you can see an example here of a patient who had a very nice response to that. Total skin electron beam therapy is a way of providing radiation to the entire skin surface. And this can be done via the rotational method, which is illustrated here, or by assuming a series of standardized poses. But the goal here is to provide uniform delivery of radiation to the entire skin surface. And lately, we've been finding that this can be used in a more limited overall dose than was given historically, and therefore you can avoid some of the long-term side effects of radiation, as well as be able to redose someone in the future if they need it. There are some important side effects that the radiation oncologists, will certainly detail with any potential candidates for this type of therapy. But I think it's important to look at how does this work and how long do people enjoy the benefit from this therapy. So what we've noticed is that how long you're clear really correlates with how much disease you had at the beginning of treatment. And so those who had more limited disease enjoyed longer periods of disease clearance, whereas patients who had stage 3 disease usually had less than a year where they were clear. I've seen many patients who were treated with radiation and cleared up, total skin electron beam, cleared up completely, but less than 3 months later had recurrent tumors. So it certainly isn't something that is curative. Definitely can't be used as monotherapy, and many practitioners are looking at giving 1/3 of the standard historical dose and then combining it with other types of therapy to be used almost in a maintenance phase so that you can try to extend that duration of the benefit. So moving on to a discussion of extracorporeal photopheresis, or ECP, and this is a patient who's getting ECP in this photo. The way that this works is by treating the blood. This is most appropriate for patients who have either a lot of disease in the blood or full-blown Sézary patients. Advanced here. So what you're doing is you're pulling the blood out of the patient, you separate out the red blood cells, send those right back to the patient. You withdraw the white blood cells, the lymphocytes, the cells that are causing the problem. You mix them with sorolins, which is a type of medication that causes the usually dynamic, constantly spinning DNA double helix to get sort of jammed up. And I explain this to patients as if someone put a twig in the spokes of a bicycle wheel. All of a sudden it stops. And so that causes the DNA to break open, which releases the malignant or atypical lymphocytic DNA material out into the greater circulation. You then reinfuse that material back into the patient, and it essentially helps your immune system to better identify the abnormal cells or the proteins inside those malignant lymphocytes, and therefore hopefully will enhance your immune response to try and clear out some of that malignancy. So it basically unmasks the DNA of the atypical or malignant lymphocytes. So it's a form of immune therapy, systemic immune therapy. All right, moving on to retinoids. So retinoids are vitamin A analogs. They've been used in CTCL forever, and they function as biologic modifiers of skin cells. We know that they modulate how cells grow and how they differentiate. They also can cause cells to undergo something called apoptosis, or programmed cell death, and that the DNA fragmentation is very sensitive in T cell lines. So applicable here. Here you can see how there's activity within the nucleus on the double helix of the DNA, and this can affect which peptides are formed and how proteins are synthesized within the cell. Bexarotene is the main oral retinoid that we use in CTCL. This was approved in 1999 and licensed in the early 2000s as a 75 milligram capsule, shown to be effective and safe in early stage CTCL as well as more advanced stage disease. So there are a series of modulations that occur here, but suffice it to say, all of these things are ways to basically cause the atypical cells to die in a targeted fashion, and therefore reducing the overall burden of malignant T lymphocytes in CTCL. let's move on here in the interest of time. So it can be used either alone or in combination with other types of therapies. The starting dose is usually 300 milligrams per meter squared per day. There are two major known side effects that occur in virtually all patients that take this drug. One is that it suppresses signals to your thyroid gland, so you're going to decrease the amount of thyroid hormone that your body will produce, and also it drives up your triglycerides, your cholesterol. If there's no response in a patient after 8 weeks on the initial dose, then you may continue to escalate the dose as long as you're monitoring for the side effects and treating for the side effects. Most patients in anticipation of those side effects are also started at the same time that they begin their oral Bexarotene. They're also started on a triglyceride lowering agent as well as thyroid replacement. And then again, you have to really monitor things closely. So here's some efficacy data, just looking at several trials evaluating Bexarotene in CTCL patients. And you can see that the overall response rate kind of varied widely, forgive me, from 24% to 78%. I think this last study, there was only one patient in that study, and I'm glad that he got a CR, but I don't think we can really qualify that as being 100% response rate. So in real time, it works in about 1/3 of patients, which is pretty standard for most of our systemic therapies. Here are two very successful examples. You can see a patient on the left who had Sézary syndrome with thickened infiltrated plaques, mainly over the head and neck area. This is him in panel B after being treated with Bexarotene and then reduced to a very low maintenance dose of only 1 capsule per day with good durable results. And then similarly, on the right in that panel, you see a 2A patient before and then 6 months after being treated with Bexarotene, and there's a nice clearance of disease there. All right, moving on to a class of drugs called antimetabolites. These mean drugs that interrupt cellular cycling or cellular proliferation in malignant cells. The first drug is Doxorubicin, and the way that it works is it kind of jams itself in between the double helix of DNA, and it essentially causes the cells to break open. It causes cellular damage and they die. This is given through an IV every 2 to 3 weeks, and the overall response rates in CTCL patients have been reported to be as high as 88%. There is sort of a rate-limiting cumulative dose, so you can't get this drug forever because it causes some changes in the heart muscle. So it's only for a finite period of time that you can dose patients with Doxil or Doxorubicin. The next drug is called Gemcitabine or Gemzar. This is also given via IV. It's given on days 1, 8, and 15 for usually about 6 or more cycles. The overall response rate in one study was quoted as 68%, and this was importantly in patients who'd already failed a couple other drugs. So this drug can be very effective. We use it in, yes, ma'am. Oh, I'm sorry.
I was just going to say, no, that's, yeah, just wanted to reiterate to our folks that are joining us to they'll be able to write their questions and their comments, and then we'll answer them when we get to the end of the program, because people have joined us as we've been going along. So just wanted to give them a little bit of a refresher. Okay. Onward. This is so good. This is fabulous.
Thank you. I'm glad that people are joining us, and I'm more than happy to answer questions at the end. So please make sure you send in anything that comes to mind. So in our clinic, we tend to use gemcitabine in patients who have tumors, big bulky disease, because it is pretty effective in shrinking those up. This isn't a drug that I would reach for in patients with just plaques or widespread patch stage disease. Definitely more of a useful debulking agent. So pralatrexate, this is a fairly newer drug in an old category called antifolate drugs. It was approved initially for refractory peripheral T-cell lymphoma. Malignant T cells overexpress a certain type of receptor called a folate carrier 1 receptor. And what happens is pralatrexate has a very high affinity for RFC1, and it goes into the cell where it becomes polyglutamilated, which basically means that it's allowed to kind of linger within the cell to assert its mechanism of action, which is blocking purine synthesis, and this results in cellular death of malignant lymphocytes in this case. So the main study that I'll talk about here looked at 111 patients. They were given IV pralatrexate weekly for 6 weeks, and there was an overall response rate of 27%. So again, not amazing results with this, but overall most drugs have about a 1 in 3 chance of being effective. There are some studies that quote higher numbers, and you really need to dig into those specific studies to see why those individuals had, why those researchers may have had better results. So pralatrexate, again, the majority of responses with this drug were observed in the study within the first cycle, so pretty quick response. One major adverse event that occurs with this drug is that people have a lot of oral ulcers and sloughing of the oral mucosa, and that's because you're basically targeting the most quickly cycling cells. As I mentioned before, malignant cells of many different types of cancers grow much faster and replicate much faster than healthy cells. So when you start to introduce these types of drugs, it's those malignant cells that are going to die off more quickly, but then also areas of the body where you might have more rapid cycling of cells, like say in the mouth, can also get targeted. And so patients will often run into something called mucositis or some oral ulcers. Okay, now talking about targeted therapies. And what targeted therapies mean is that you're not just giving a drug that kind of stops all cells from proliferating, and then hopefully you'll get the most rapidly cycling cancer cells with little collateral damage to healthy cells. Targeted therapies refer to classes of drugs that interrupt at specific points or that target specific cells that have protein markers that are ready targets for these drugs. So there tend to be fewer side effects with this category of drugs on the whole. And these are newer in general. And it includes a bunch of different drugs that we'll go over today. They're all listed here. So starting with the category of drugs called HDAC inhibitors or histone deacetylase inhibitors, this is a big group of drugs. And basically what they do is they try to get back to that epigenetic dysregulation. So that one slide where we talked about epigenetics really referred to some combination of predisposed, environmental factors, predisposed genetic factors, plus environmental factors, plus aging, plus diet, etc., that results in dysregulation of cellular cycling. So what that means is that usually in the healthy state, all cells in our body have signals to grow when they reach maturity, signals to rest, and then when it's time for those cells to become senescent or to die off before they become old and abnormal, then we have some programmed cell death signals so that we have, young, healthy cells floating around at any time. With cancers, what they're able to do is sort of manipulate this whole system, or maybe they result from the manipulation in the first place. But the problem is you've got kind of unchecked pro-growth signals, the absence of targeted programmed cell death signals. And so you get this unrestricted, fast growing of abnormal cells. And that's a very, as I mentioned, complex system. So what HDAC inhibitors try to do as a whole is just kind of revert back to normal cellular protein synthesis, normal cellular cycling. And so it has a big global effect. We're not exactly sure what it's doing in CTCL, but it's kind of pushing the whole system back toward the normal cellular cycling state. And that results in slower death of abnormal cells than, say, a gemcitabine, which kills abnormal cells, but it also can be used in the long run without as much collateral damage. So this is another very useful type of drug. The oral version is called Vorinostat. There were two main phase 2 trials looking at this drug. Both of them had response rates reported in the 24 to 30% range. The larger study had 74 patients. It had a higher overall response rate of 30%. Median duration of that benefit was 168 days. Romidepsin is the infused version of HDAC inhibitors. It's given on days 1, 8, and 21 of each 28-day cycle. It was shown early on to be effective in the laboratory in killing CTCL cells, and then it was approved in 2009. There were two main studies, one done at NCI, notably, where we looked at 71 patients. The overall response rate was 34%. And then a follow-up study, which was smaller, still had a similar overall response rate of about 31%. The median time to response was 2 months. So again, it takes longer to kick in. I don't know if you remember, but pralatrexate, for example, seemed to work in the first cycle. Romidepsin takes longer. And again, it's not killing tumor cells. It's just shifting the whole system back to normal. And so it's depriving those tumor cells of their otherwise haywire growth signals. The median time to progression of disease, which means how long were these people enjoying the benefit of this drug before symptoms got worse, was a little over a year. And I like this drug because it has good activity in multiple compartments. So it works in the lymph nodes, it works in the bloodstream, and it does have good activity in the skin as well. Also, we've been able to use this drug with some success in a maintenance regimen for some patients, dosing them every 4 to 6 weeks, and we've been able to maintain response for a few years in some of our patients. So that's also very useful. There are a couple investigational HDACs that are exciting as well. All right, for adenosine, this is not a drug that is used all that widely. It's called a PNP analog. It's been studied in both infused and oral forms. There was one big initial study of phase 2 looking at 144 patients, and it showed an overall response rate of 11%. So not something that would be first or second or even third line therapy, but may be useful for patients who failed a bunch of other drugs and you're looking for other options. Here is one encouraging example of a patient on the left who had classic plaque stage disease. There's obvious improvement in the lower panel, panel B, and then on the right here you can see an erythrodermic patient who certainly was improved after treatment with this drug. Lenalinomide, this is in the same class as thalidomide. Most people have heard of that. We're not totally sure how it works, but we know that it seems to kind of tip the scales back toward Th1, which you may recall is the anti-malignancy, antiviral sphere of functionality in the immune system. And so that can help as you're trying to target and kill a malignant clone that's causing the problem in CTCL. It's administered orally. And there have been some small studies looking at this, notably one that was looking at 32 patients with an overall response rate of 28%. Okay, now monoclonal antibodies will be next. So Campath or Alemtuzumab is an anti-CD52 antigen. So CD52 is expressed abundantly. That's a protein marker. It's almost like an address that the cell might have. And it is very highly expressed on malignant CD4 cells, and in CTCL, at least classic MF subtype, the malignancy is in CD4 positive cells. We think that it works through some combination of depleting those lymphocytes and then also activating Tregs, which is kind of like an immune therapy against the malignancy. So it was studied in Sézary syndrome patients with amazingly successful results. Overall response rates were reported between 86 and 100%. It's given through a shot, so you don't have to get it in an IV. You get it through like a submuscular injection. It's done at a doctor's office, and it's done 3 times per week. Another interesting thing about Campath is that you can kind of customize the regimen, so you can treat a patient 3 times a week for a month, and if they look good right away, you can kind of hold off and see how they're doing. And if their symptoms start flaring again, you may give them another 2 to 4 weeks of therapy. And many patients who were retreated had a secondary response, so that's good. Here, I think this is a really good illustration of identifying which compartment you've got disease in and then choosing your drug appropriately. So the left 3 panels are a single patient who had clearly blood-borne disease. That's why he's erythrodermic, and you can see that Campath worked quite well. The second, or the rightmost 2 panels, panel B, this is a patient who had skin disease in the effector memory skin resident cells. You know, there are plaques there. Campath didn't work very well. That's because Campath works in the bloodstream, very little activity in the skin. So it's really only appropriate for patients who have blood disease rather than skin disease. I'll skip this one because it's a little bit basic science. Okay, Brentuximab. This is an anti-CD30 monoclonal antibody. This is approved in anaplastic large cell lymphoma and mycosis fungoides. It's also used in lymphomatoid papulosis, and it's infused once every 3 weeks. So this particular antibody gains entrance into the cell where it then disrupts the microtubule network, it's called, and this results in cell cycle arrest and death of the malignant cells. There were 2 main studies looking at this. The first one looked at both mycosis fungoides and Sézary patients, 19 of them in total, and noted a 68% response rate with a median duration of that response being 27 weeks. Another study looked at both mycosis fungoides patients, primary cutaneous anaplastic large cell lymphoma patients, and LYP patients, and those overall response rates were pretty high as well, 71%. And then when you sort of substratified for just LYP or anaplastic large cell lymphoma, it worked in 100% of those patients. So this is pretty exciting. It's interesting to note that the response rates did not seem to correlate with how much CD30 positivity any given disease had. And that's interesting. And there have been a couple theories to propose why that is, which I'm happy to talk about at the end if there's any interest. The major drawback with this drug is that sensory neuropathy has been reported in a large proportion of patients, 67% of patients. And this may be severe and it may be permanent. So this is a big problem. This drug really works, but we use it very carefully. We basically dose until people are better and then hold back. And we're very, very sensitive in questioning patients about any early symptoms of sensory neuropathy, because once it develops, it can be permanent in upwards of 20% of patients. So the main trial was called the ALCANZA trial, and this was looking at single agent Brentuximab versus the doctor's choice of either methotrexate or Bexarotene, and it was looking at patients who had CD30 positive anaplastic large cell lymphoma and or MF. So the overall response rate at greater than 4 months was 60+% compared with only 8% in the control arm. And the median progression-free survival, which again means how long these patients were stable with that response before their disease started to recur, was almost 16 months versus 4 months in the control arm. The complete response rate was 18+% compared to 0% in the control arm. So it definitely, the ALCANZA trial definitely showed that this drug works. And here we see a lovely example of a patient. This is pre-treatment up here. He's got a lot of tumors, and then this is post-treatment, very clear with regrowth of hair. So it's definitely effective. Zanolimumab, this is an anti-CD4 monoclonal antibody. There were 2 open label phase 2 trials looking at this drug. The overall response rate was quoted as being 56%, and the median duration was 81 weeks. So that's pretty exciting. Unfortunately, the follow-up phase 3 trial was initiated but then halted, and this was due to kind of abandonment by the pharmaceutical company. So it's impossible to get our hands on this drug unless the pharmaceutical company decides to reactivate the trials. This is one of the newer drugs to come to market, mogamulizumab. This is an anti-CCR4 monoclonal antibody. CCR4 is upregulated in CTCL cells, and it allows them basically to traffic themselves out of the bloodstream and up into the skin where they wreak havoc. Essentially, this drug results in antibody-dependent cellular killing. So it basically gets into the abnormal cells and then kills them. So I like this diagram because what we're looking at again here, just to orient you, over here you've got normal skin, here you've got early patch stage disease, progressing to plaques, progressing to tumors, progressing to erythroderma. Down here you've got the blood vessel, this is the skin, and what you see is that CCR4 right here is the molecule that is used to be able to gain entrance into the skin and then cause problems. And the red cells represent the malignant CD4 positive cells in CTCL. So this particular drug goes in there and basically just blocks these cells from having access into the skin. In the Maverick study, yes, ma'am.
No, I was just going to say we're going to do a whole show on mogamulizumab in October.
Okay.
So
wonderful.
Hopefully we'll have, we're waiting for the FDA approval, which hasn't come through yet. So we're waiting on that, but this is just gives you a little teaser.
Right, and I'll go over where we stand with that, but they're really right on the cusp of it being available in pharmacies. But basically the major study, the phase 3 study, involved 372 advanced stage disease patients who had failed at least one prior systemic therapy. This drug was infused, so through an IV weekly for 4 doses in cycle 1, and then every other week from there. The overall response rate was 28%, which is pretty good. And then it's important to know that there is one potential flag, and that is that there's been some recent evidence that patients who go on to get stem cell transplant may suffer really severe graft versus host disease if they were previously treated with this drug. And we think that that may be due to some collateral damage that the drug has on Tregs. Tregs are sort of the anti-autoimmune disease cells in our skin. And so that's something to keep in mind. If you've got every patient that we see, I try and think about their long term before we choose any therapy for them. And this is one thing to keep in mind, is that if you've got a patient who you feel is young and healthy otherwise, has really advanced disease, and may want to achieve cure via stem cell transplant, you need to think very carefully before you expose them to this drug, because it may increase their risk of severe graft versus host disease down the road. There are also some drugs that are microRNA targets. It's been shown that there's upregulation of microRNA 155 and 92A, as well as 93 in tumor stage MF. And downregulation has also been observed in microRNA 150 in advanced CTCL, and that was strongly associated with tumor metastasis. So basically, this sort of preclinical data, lab-based research, allowed us to identify some targets here. So it was determined that microRNA 155 may be a potential target for drugs in CTCL, and so therefore an antagonist for microRNA 155 was developed, and this was given by both injecting it directly into tumors early on and then ultimately through an IV. And the phase 1 is completed. They're moving on to phase 2 now. I had 2 patients who enrolled in this study. Our results were not in line with what has been reported nationally. I think the national results have been a little bit more encouraging, but study is ongoing for that. Now, moving on to a category of drugs that I think probably has the most buzz right now in oncology in general, the immune checkpoint inhibitors. This is a very exciting category of drugs. This is the group of drugs that many people ask about, how patients who have advanced stage melanoma are doing so well. Jimmy Carter, how is he suddenly no evidence of disease after having advanced stage melanoma? This is the category of drugs that he's been treated with. And it's been used in multiple different other types of malignancies. And so now we're starting to look at it in CTCL as well. So basically, immune checkpoint molecules ensure appropriate immune function by modulating how T cells are activated and not activated. And they tend to augment the anti-malignancy immune function. They've been shown to be useful both alone and in combo therapy in melanoma as well as other diseases. As I mentioned, there are some autoimmune type side effects that occur. So here's a nice diagram that just kind of shows why this works. So down here, you can see that you've got your T cell, and you've got this receptor called a CTLA4 receptor, and then you've got a B7 that basically comes in and activates it. And so once you get that ball and socket activation, the T cell gets activated and it can start to attack any malignant cells that might be floating around. Tumor cells are very smart, and they tend to stimulate something that deactivates the T cell. So essentially the tumor cell doesn't want the T cell to get activated and start to kill it. So it sticks up a certain receptor that will bind with the T cell that will shut the T cell down so that the malignant cell can float around unharmed and can evade immune attack essentially. So what these drugs do is they come in there and they interrupt the ability of the tumor cell to turn off the immune cell. And so it's very useful because it basically weaponizes your own immune system against the malignancy. So starting with Ipilimumab, this is the anti-CTLA4 antibody. There is good bench evidence or preclinical evidence that CTLA4 is overexpressed in CTCL cell lines. And we've discovered that disinhibition of cytotoxic T cell responses can result in tumor destruction. So there's very limited preclinical data looking at this, but there was one interesting case report that documented a durable remission of a stage 1A patient who happened to have melanoma and received ipilimumab for the melanoma, and it seemed to completely clear the CTCL as well. So moving on here. So then we'll also talk about the anti-PD-1 antibody, pembrolizumab or nivolumab. And here's just another good schematic. I like pictures because I think it helps people to understand what we're talking about. So this is what I was kind of stumbling over a moment ago, forgive me, trying to describe. But here's the tumor cell, and it sticks out this particular protein, and then it binds with something called PD-1 on your T cell, and it turns that T cell off. So it turns tumor killing off. When you throw the drug in, it blocks the receptor on the T cell so that the tumor can't turn it off, and now the T cell is activated and tumor killing is turned on. So again, you're weaponizing your own immune system. It's a form of immune therapy. The main problem with this category of drugs is that it may sort of skew the balance of your immune system, which usually is always balancing anti-cancer, antiviral functionality from self-tolerance. And when you start to skew it too much this way, you can lose some of your self-tolerance, which results in some autoimmune type side effects. So that's one thing to keep in mind. And if a patient has any sort of autoimmune disease in their history, this category of drugs is probably not going to be useful for them. And similarly, anybody who's received a transplanted organ probably is not a good candidate for this type of drug because it would then increase their chance of attacking the donated organ. So again, just a couple more details about the anti-PD-1 antibody. There was one small study that showed that Sézary cells highly express this particular protein versus early stage MF and healthy controls. And then again, lab research or preclinical data showed that PD-1 blockade in CTCL cell lines did in fact result in an increase in interferon production, that's anti-cancer chemokines, a shift toward anti-cancer functionality, a Th1 shift, and this all resulted in death of the malignant cells. So there's a phase 2 study that's being led by the Cancer Immunotherapy Trials Network looking at 24 advanced stage patients, and an overall response rate was initially reported at 38%, so very encouraging. Here are a list of some of the current trials looking at pembrolizumab in CTCL patients. We have a couple patients who are up at Penn working with Drs. Rook and Kim getting this drug, and both of them are doing incredibly well. I'm very excited about this category of drugs in at least patients who have blood-borne disease or very advanced stage disease. Also, it was added to the guidelines for Sézary syndrome. So in some patients who failed 2 other prior systemic therapies, in some cases we may be able to try and obtain the drug just as a standard of care measure. But I'm not sure how long we'll be able to get away with that. So it's probably more important that we establish how the disease is affected by this type of therapy in a controlled setting. So if you're interested, try to find a clinical trial near you. Okay, just a few more words about treatment here. Stem cell transplant is currently being hailed as the only curative therapy in CTCL. Everything else pretty much is aiming toward remission, but stem cell transplant can offer the possibility of cure. So allogeneic stem cell transplant can be appropriate for a subset of patients with advanced stage disease who are otherwise young and healthy. You have to achieve really good disease control prior to transplant, so that's sort of counterintuitive because most people think, well, this will be my last ditch effort, and that's actually not the case. You need to make sure that you've got the disease completely controlled, if not, almost eradicated, or have them in a complete response before you send them to transplant. And what happens is your own immune system is essentially wiped out, and then you are given a donor immune system that's transplanted. And the goal is to have that new donor immune system, which hopefully does not have this fragility or susceptibility towards CTCL, take over and then be able to fight off the CTCL cells. So Dr. Duvik looked at 47 patients treated with allogeneic stem cell transplant in the 2000s, and these are the results here. And what you can see is that most of the patients had pretty advanced disease. There were some 2B patients, but most of them were 4A and 4B patients. And the incidence of disease progression or relapse after transplant was about 50%. So about half the patients who responded went on to either relapse or develop recurrent disease. The progression-free survival at 4 years, so the people who had no disease 4 years after transplant, was only about 26%. But among the Sézary syndrome patients, progression-free survival was much higher, 73% at 4 years. So digging into more details here, 22 patients went on to receive an additional therapy, and 8 of those 22 went on to achieve a second complete response. Of the relapsed patients, they received immunosuppression withdrawal, some skin-directed therapies, ECP, and/or chemo. And 2 patients received something called a donor lymphocyte infusion. So the net of it is that although post-stem cell transplant relapse rates are relatively high, 50%, many of those patients do respond to other therapies and go on to achieve a durable remission. So, in summary, there frustratingly is no specific treatment algorithm in CTCL. Most systemic drugs have a maximum overall response rate of about 30% in advanced stage disease. You need to consider where you've got disease, which compartment is involved, and then identify potential disease targets. We usually need to utilize combination regimens in the advanced disease state. And then also we need to recognize the chronic nature of CTCL. So I think it's really important to have an open dialogue with patients about the fact that our goal is to get remission and try to get durable remission, but that this is a chronic disease, and without some kind of ongoing maintenance therapy, we can expect that it will recur. As we start to move forward, we need to utilize something called next-generation sequencing and genomic studies to try to search for CTCL biomarkers. So basically what that means is we need to look at who's responding well to certain drugs and then try to find unifying characteristics of those people so that we can better understand why certain interventions are successful in patients who have certain disease features. We also need to be able to design more flexible trials so that we can look at a multitude of variables at once in a relatively small patient population. This will help us better characterize epigenetic shifts in CTCL, help us start to examine how the transcriptome might be different or altered in the setting of effective therapy. And then we can start to identify, who are these exceptional responders and why. And then we can be able to generate therapeutic directions based on more personalized features of disease, the way that we are in other types of oncology diagnoses. We also need to continue to look at how drug combinations work, how they're addressing complementary mechanisms, and then we also need to evaluate how combinations of drugs may impact safety. We need well-designed combination therapy to start to be able to look at how these drugs are acting synergistically to target malignant cells and restore epigenetic functioning. And then our ultimate goal, of course, is to achieve long-term remission in patients with advanced stage disease. So now, hopefully, we've got plenty of time to go to questions.
We do. Thank you so much. That was terrific, and I loved all of your diagrams. It really, I think, makes it simpler to understand what is really complicated under the surface, and I'm really excited about all the work that's being done. So, thank you for kind of laying the groundwork on that. And so we'll go to questions, so we can let you off the hook in a few minutes and go back to your family.
No problem. I can say no problem.
Great, thank you. So, Mike, can you post our first question? Okay. Their most recent level for CD4 positive, CD26 negative absolute is 959. They've been on Targretin 225 milligrams per day since March. Is this 959 level indicative of a need to add photopheresis? They've now been on Targretin for about 4 months. In early March, their CD4 positive, CD26 negative absolute level was 1312. And they're also getting UVB therapy, 1 joule 3 times a week. So it's probably no, I shouldn't say classic because there's no classic cases, but for someone that we're able to use a combination of therapies, I think one of the challenges from a patient perspective is, how do you know if this is really working? And I think that was pretty detailed for someone knowing all of their different levels and the different markers and so forth. But maybe you can kind of comment on how do we know when and if and what kinds of levels should patients be working with their doctors on, so they can look at, are things working, are they not? As we know, sometimes it takes a while for things to work.
That's true. So this is a complex question, and I usually go with the flow cytometry values. So the absolute values are a little bit trickier for me because it's just not the language that I'm used to using. I'm used to relying on the percentages from the flow cytometry, but it sounds like, a moderate burden of disease in the blood. So when we evaluate patients, the one encouraging thing about CTCL is that you're never going to have a huge burden of blood disease and be totally asymptomatic in the skin. So when patients have disease that is progressing or not responding, you're going to see symptoms. You're going to see clinical evidence of that, and you're going to hear them explain symptoms to you. So a patient who has a burden of disease in the blood that is still erythrodermic or that is profoundly pruritic or itching is someone who's not yet successfully treated. And so in that situation, I would combine both the clinical picture with what I see in labs and see maybe we do need to augment the therapy here. You've got narrowband hitting the skin. That's great. That's your skin target. You've got Bexarotene, which has activity both in the skin and in the bloodstream. But if the patient is still symptomatic and they're not trending down in their labs, symptomatic and not trending down, and you don't want to do a flow cytometry or a Cesare prep too frequently, the earliest that you can repeat that test to look for a trend would be 3-4 months. Then in that case, you might want to think about adding either ECP or interferon or something that's going to further target the blood-borne disease component. However, if the patient is looking and feeling better, then I would kind of wait a while on that. And you may want to give a longer period of time before you reassess what's going on in the blood to be able to measure a trend. And even if you see a slow trend toward improvement, I would give the current regimen more time to work. So it's hard for me to make a recommendation based solely on labs. I would need to get the history of how symptoms have been progressing. I'd like to know what's present on the skin and then make a decision from there. But to just further round out that question, I have a lot of patients who have very limited disease in the skin, but when we do the initial staging and check the blood, they have something called B1 stage disease, which means that they don't have full-blown Sézary, but there's definitely a measurable clone in the blood. If those patients are largely asymptomatic, there are a couple options in how you can do that. You can be very aggressive, put them on ECP, give them interferon, try to drive those numbers down, or you can monitor them and recheck the blood twice a year and look for stability. And if they're not trending upward, I do feel comfortable in a handful of patients monitoring that, as opposed to trying to give them aggressive systemic therapies to simply drive down a laboratory value. And then there is a difference of opinion on that front. And you also need to take into play what the patient's preferences are. Some patients really want those labs to normalize, and the amount of anxiety and fear that they feel knowing that they're in the B1 category impacts their overall health as well. And so for those individuals, you may want to, in coordination with them and their families, pursue an additional layer of therapy to try to drive those labs toward normal. But it's more complex than just looking at labs.
Right. And so it goes back to being an informed patient, having a good relationship with your physician, and looking at all of the different the risks, the quality of life, the impact on the whole picture, as you're looking at what should the treatment protocol be, and then depending upon, and again, I think some of this comes down to the individuals, as you mentioned, the way how do people emotionally handle. You might need to be on a treatment or a combination for 3 to 6 months before you really begin to see the impact. So you have to have some patience, which can be very frustrating or frightening for some people, because it's hard to go through treatment and not know if it's really working or not. So it's really a personal, individual discussion and relationship that you build with your physician as we work through, our own individual diseases and treatments and what works the best for all of us.
I agree. I agree with you.
Yeah.
And another thing that's important to note is that we don't have any good evidence that intervention will arrest progression to more advanced disease. So, that's a question that I get all the time, and we don't really know the answer. But, many patients say, well, if I've got something in my blood, we have to treat it or else it's going to get worse. That may not be the case. It may be that people who have B1 disease without therapy will never move beyond B1. So we don't have good evidence, because we just don't have large enough data pools, essentially, to be able to determine if intervention in the moderate blood level scenario will prevent progression to advanced blood burden of disease. So that's another thing that's important, and I think a big decision-making factor for patients, because I think the natural assumption is if I don't jump in with therapy, I'm going to get worse, and that may not be the case. We don't totally know yet.
Right, but we're working on that, so that's a good thing.
Yeah.
Just really looking. Okay, so we have about a half a dozen more questions. I just want to check in on your time and make sure you're okay. Okay.
Yeah, I'm good.
It's you're good? Okay. Somewhere legitimate, I thought. I recently read that checkpoint inhibitors should no longer be used in lymphomas in general because of poor outcomes. Could that be correct? Maybe it was the autoimmune issue you mentioned.
It depends if you're talking about cutaneous lymphomas or systemic lymphomas, because checkpoint inhibitors are also being used in systemic lymphomas. We have so little specific data. I mean, just very, very early clinical trial data. That one study that I mentioned, most of the trials are still active right now. So there's really no way to say that it shouldn't be used, because we don't have the final numbers from the bulk of the studies. So I'm not sure where that commentary was coming from, but I'd have to kind of respectfully disagree with that, because I don't think that we've given our clinical trials that are currently active enough time to give us outcome data. And
which
some
again
of
is, go ahead.
Oh, sorry. And
No, go
the
ahead.
autoimmune side effects, because I also work, in a melanoma center, a lot of our patients are on these drugs. The autoimmune problems, we can deal with those, fairly readily. So it's not as if these are life-threatening in multiple patients. So I'm not quite sure where that commentary was coming from, but I remain very excited and hopeful and optimistic about immune checkpoint inhibitors in at least advanced stage disease, in bloodborne disease. If people have skin limited disease, I'm not sure.
Right. So another plug for the importance of clinical trials and being able to collect the data so that we can fully understand and appreciate what works best and all those good things. So, okay, let's see. Is the flow cytometry test the best test to tell me if my Sézary is improving or not? And within the flow cytometry, okay, good, that's a yes.
Go ahead.
And within the flow cytometry test, is the most important component of that test the CD4 positive, CD26 negative absolute?
No. So I think that, there are basically three main things that you look at in flow cytometry. One is the CD4 to 8 ratio. One is the 4 positive, 7 negative, and one is the 4 positive, 26 negative. And all three of them need to be considered and almost equally weighted. I recently had a discussion with the manager of our flow cytometry lab, the guy who manages the technical side, and he indicated that the 26 negative antibody can be sort of hard to standardize across various labs. So I think that one might actually be the weakest. To kind of better answer your first question, which is flow cytometry the gold standard? I think it is, because the staging system, is moving toward really relying on those values as opposed to the more old-fashioned standard Sézary count. Also, the standard Sézary count can be very subjective, whereas the flow cytometry value, that's an automated, machine-derived, pretty objective value. So I think you got to wait. Yes, it's the best test, and you got to weight all three of those parameters fairly equally.
Right. And that's usually for folks with bloodborne disease as the best, right? Versus,
yes.
Okay, very good. Okay, I have Sézary syndrome. My last flow cytometry shows 959 count for the CD4 positive, CD26 negative absolute. Questions are as follows. Okay, next questions, Mike.
Actually, we had his question. We had his question, so I'll grab
okay.
another one. Sorry.
We did his question. Okay. Well,
yeah, I thought that 949 sounded familiar.
Yeah, that was the same familiar, right? And I think maybe one of our next, we might do just, how do you read your labs would be a good Q&A to give people what's important, what's not. Okay. Next question. Is there a way to make stem cell transplants safer? I read that there was research aimed to prepare patients with the antibody CD45, not harming the organs and side effects. So of any other methods that improve outcomes?
So I think it was 3 years ago, Susan, maybe you can correct me. I believe it was in 2016 that the USCLC annual meeting was based entirely on stem cell transplant and outcomes. And there are, various institutions in the US that are conducting stem cell transplant for CTCL. So there are various preparatory protocols. And the data that was presented most recently to me, so what I'm most up to date on, showed that while there are some small differences based on various protocols, overall, they're pretty much equivocal. I'm not a transplant specialist, so I'm not entirely, I don't think that I'm expert in answering that question, because I understand the process and I'm privy to some of the data, but I don't know the specifics of, prepping people with CD45 treatment prior to try to protect Tregs to decrease or enhance GVH or graft versus lymphoma phenomenon. So I will respectfully say that I don't think I'm the best person to answer that question. I think that I know that at Penn, at all of the major institutions, they're exploring various preparatory protocols and looking at how that might impact both the success of the graft in clearing the lymphoma and the incidence of graft versus host disease. I mean, the classic dilemma is, basically you got two competing outcomes. One is you've got a great graft versus leukemia effect, and so you have better outcomes in terms of clearing the lymphoma. Sorry, I meant graft versus lymphoma, but then you've got a lot of graft versus host disease, which if it goes on to be moderate to severe and chronic, can be life-altering and in some cases worse than the primary disease process. Or do you carefully, give a lot of immunosuppressants with the transplant to control for graft versus host, but then not be able to optimize your graft versus lymphoma effect. So those are the main two kind of camps in terms of how you should frame your stem cell regimen. And you'll find a lot of variation from institution to institution. So I think that we don't totally understand what the clear, superior approach is, but that people are actively looking at it, and I'm not the best person to answer that. I apologize.
Yeah, no, I think that's fair enough. And, that might be another one of our topics. We'll just do stem cell. And I also know that there is a lot of international collaborative work where the institutions are pooling their data and discussing the various regimens and trying to, look overall to come up with a standardization, but we just don't have enough data yet, at least as far as I can tell. So, but people are working on it. So hopefully we'll get there.
Yeah.
Okay. So next question. What is the washout period after you receive Campath before you receive transplant? Her husband is stage 4A Sézary, currently on photopheresis, Bexarotene, and Actimune. So that's an interferon.
So the concern there is when you take Campath, you hit the malignant CD4 cells, but there are a lot of healthy immune cells that also have CD52 protein markers that get wiped out. So I think the kind of the bare minimum washout period is likely going to be about 6 months. Overall, that's the guideline that we use when we advise patients that they can withdraw their prophylactic antiviral and antibacterial drugs, because we have noted that there seems to be recovery of healthy immune cells that were wiped out with the anti-CD52 drug Campath. So I would say probably in the 6-month range.
Okay, great. All right, we are seeing continued comments on the CTCL listserv about the Shingrix vaccine. Yes, especially for those with advanced disease. Generally speaking, is Shingrix safe for such patients?
Yeah, there's a lot of differing opinions on this as well. So when you have advanced stage disease or Sézary syndrome, you are immunosuppressed. You've got a malignancy affecting your immune system and you're immunosuppressed. So any live viruses in vaccines should be avoided. I know that they're working on a new killed virus vaccine for varicella, and that may be a reasonable option. But I would be very leery of any live viruses in patients with stage 4 disease, just because of the immunosuppressed component.
Right, and I think the new Shingrix is the brand name of the new dead virus.
Yeah, so the dead one should be fine.
I also don't know that we have data. I don't know if anybody's following, in more advanced cutaneous lymphoma patients, if there is any adverse reactions or, that those folks that have done the new dead virus. So it's probably something we should look at and maybe bring up at the next USCLC meeting to take a look. Okay, next question. Great informative presentation. I totally agree. Just finished 6 rounds of EPOCH for large cell transformation. PET is scheduled for August 27th. Looking for remission. Would I be a candidate for immunotherapy?
Potentially. So I'd like to know some details on the initial disease presentation, how much large cell transformed disease was there? Was it in the lymphatics? If you were to recur, I certainly think it would be a reasonable option. And again, that's based on a tiny N, or a very small number of patients that I personally have observed improvement in with this new category of drugs. So we don't have, getting back to what we just touched on, we don't have final outcomes of the active trials. So it's hard to reflect on tangible data and say, yes, you would be a good candidate based on, inclusion criteria that we previously observed and outcomes, et cetera. But I think that it is something you should ask about. Hopefully you'll have a great remission, your PET will be clean, and everything will be fine. But should you have progression of disease or recurrence, I definitely think that you should look around and ask around about potentially becoming enrolled in one of the immune checkpoint inhibitor trials. Yes.
Good dessert. Okay. My husband has MF with Sézary syndrome and lymphanopathy. I'm not going to say that right. Enlarged lymph nodes. Thank you. He progressed on Targretin, Intron A, and ECP. He's done very well clinically on Acedrus with significant improvement in the lymph nodes, but only partial improvement in erythroderma after 4 doses. He's developed neuropathy of hands and feet into lower legs. How much longer would you, I'm trying to read, I can't continue the Acedrus?
Honestly, I would be very careful about continuing it if he's already developed sensory neuropathy. It tends to be a cumulative phenomenon, so you tend to get worsening of the sensory neuropathy with additional doses. I'd be very leery. I would probably halt it and switch gears.
Okay. Thank you. Thank you. Mike, we have some more questions, or are we about finished up? Oh, nope, one more. Okay. Comment part 1. Her husband has MF. Oh, that was the Sézary. Okay. We already answered that one. Next comment, Mike. Do you have the next question?
Yes. Let me just grab them here, and I'll just read them here. It's probably
okay. Perfect.
Quicker
That's
than
easier.
Putting them up on the screen. So let's just see here.
Right. That's what happens when we get fancy.
Yeah. My Sézary count from flow cytometry was exactly 1,000, the diagnostic cutoff at the time I was diagnosed. Your comment about progression. After I failed Romidepsin and was only on photopheresis for about a month, my count was back up to 775 from a low of about 160. I believe I have terrible skin side effects from Targretin. Would I be safe on photopheresis alone? What about nothing? Oh, sorry, I need to repeat that because I wasn't sending that audio to
Dr.
DeSimone.
You
I'm
only
sorry.
sent it to me?
I sent that to you. So here we go. Let me read that again, Dr. DeSimone. Sorry about that. My Sézary count from flow cytometry was exactly 1,000, the diagnostic cutoff at the time I was diagnosed. Your comment about progression. After I failed Romidepsin and was only on photopheresis for about a month, my count was back up to 775 from a low of about 160. I believe I have terrible skin side effects from Targretin. Would I be safe on photopheresis alone? What about nothing?
Ooh, that's a tough one. So that showed that when you were on therapy, you had a nice response in reduction in the clone in the blood, and that's good. I think that the only way to find out if you're going to be safe on ECP alone is to try ECP, see how your symptoms are, see how your clinical exam is, repeat your flow in 4 to 6 months, and look for a trend. ECP has an overall response rate, similar to some of the systemic therapy drugs. So it works roughly in 1 out of 3 people. And you don't know if you're going to be one of those 3 until you try. Would you be okay on nothing? It depends on how you look, how you feel, your clinical exam. And you would have to be closely observed with serial, frequent follow-up flow cytometry to observe for a trend toward worsening disease.
Okay.
Great.
Just a couple more here. We're almost there. Let's see. Can a LYP lesion turn into anaplastic large cell lesion if it doesn't heal?
So that's a great question. No, lymphomatoid papulosis is a benign entity. It's in the same category as anaplastic large cell lymphoma because it's a CD30 positive lymphoproliferative disorder. The issue is not transformation from LYP into anaplastic large cell lymphoma. The issue is that there's about a 20% co-disease rate. So 20% of people have both problems. So you may develop anaplastic large cell lymphoma if you have LYP 20% more often than someone who did not have LYP might get anaplastic large cell lymphoma. So typically, you know, the way that you diagnose it or differentiate it is not histopathologically because the slides look identical. It's based on the clinical exam. So in general, LYP lesions are less than 2 centimeters. They're spontaneously resolving in 6 to 9 weeks. They tend to come up in crops, etc. Whereas anaplastic large cell lymphoma tends to be larger, smoother, more dome-shaped, and fixed. So it's going to be, what you've got is going to be based on what your exam shows in addition to pathology. But to answer the question directly and specifically, can an LYP lesion, a single lesion, develop into anaplastic large cell lymphoma? No.
Okay,
Great.
Next one. My wife has a single lesion. She is on local steroids and light therapy. What are the chances that she could get another lesion? What is the cure rate for her lesion?
Okay, so most patients have stage 1A disease, which means that they have less than 10% of their body surface area involved. So that could be unilesional, could be multifocal, but less than 10% of the skin is involved. Roughly 90% of people will never progress beyond stage 1A. So that's very good. But 10 to 12% of patients will go on to develop additional disease. So I can't give you exact numbers about moving from 1 spot to 2 spots. That's never really been observed. But I can give you numbers looking at very limited disease, less than 10% of the skin is involved. 90% of those people are going to stay in that category. You know, 88 to 90% of the people are going to stay in that category. And those people have basically no impact on their overall life expectancy. So the prognosis is very good. Now, in terms of what the cure rate is going to be, this is a chronic disease. So in general, you use a therapy, you make your symptoms go away, and then they're gone for a certain period of time, but they tend to come back at some point. With light therapy, with nitrogen mustard, with light therapy, with radiation, all of those with steroids in some treatment-naive patients, all of those therapies can induce a remission, but how long that remission is going to last varies significantly and is highly individualized.
Okay.
It's got to going.
ahead,
All right,
Susan.
Mike, what else do you got?
Next
Go ahead.
one. My most recent in mid-May level for CD4 and CD26 absolute is 959. I've been
I
on.
think we talked.
Oh, we
took
did do
that
this
I
one?
think we did that one.
Okay.
We did that one.
Okay,
Yeah.
we did do that one. Okay, just checking to see if there's
Yep.
any others that we missed. Let's see. I think. Let's see, we talked about the. How long can someone live with Sézary stage 4?
So for in the past, when we're looking at prognostic data, the 5-year survival for stage 4, is about 20%. So not that great. However, it doesn't take into account 2 major factors. 1, we've had an explosion of new drugs in the last 5 years. And 2, this particular disease is highly individualized. And so there can be major outliers in the survival trends. But in general, stage 4 disease is advanced and serious disease, and people tend to have a hard time, and it does impact life expectancy significantly.
Right. And the good news is that there's a lot of work being done, and we've got a lot of clinical trials that are ongoing.
Yes.
And with, I think in the next 5 years, we'll have way more options in the toolbox. We'll know
I agree.
which people to treat with which
Yes.
drugs and which therapies in a lot
Yes.
better way than we do today. And I think that'll definitely impact outcomes. I'm very hopeful, especially for folks
I
with
am too.
advanced disease. Yes,
Yeah,
good.
it's exciting.
Well, Dr. DeSimone, thank you. I think that was fabulous.
My pleasure.
I always learn something more. That was just you took a very complex discussion and I think made it very easy to understand, and really appreciate your spending the time with us tonight. Thank you so much.
Yeah. It's genuinely my pleasure. I know that this disease is really confusing. There's so little known about it. People have a hard time understanding it, let alone explaining it to concerned family members. So, anything I can do to try to help break it down or share the facts that we do have, it's really my pleasure to do so, because I think that this disease is unique in how poorly understood it is. And I think that adds an extra level of frustration and fear and confusion to our patient population. So I want to do as much as I can to help mitigate that.
Well, thank you. We appreciate that. And we really appreciate all that you've done for us. And I know you are a frequent speaker at our local DC networking group. And thank you for doing that as well, and taking all of your time.
And we have one last question. One last question that snuck in under the wire. And it's a nice, easy, simple one. Is CAR T therapy, if there is such a thing, I'm joking, is CAR T therapy good for Sézary?
We don't have enough data yet. There's hardly anything that I can talk about that is concrete on that front. I think that that's an exciting field of study for many different malignancies, and I think certainly our disease should be evaluated for that form of treatment. But I don't have any concrete data to share on that, unfortunately.
Yeah, it's sort of like stay tuned as that new form of treatment really develops and we learn a lot more, and they start to look at the options in cutaneous lymphoma. But I would say right now, I totally agree. We've got to see how it all plays out. Yeah. Mm-hmm. Yeah. So now we're going to let you go.
Okay. Well, thank you very much again.
Thank you so much. And just to let everybody know, we are going to be doing a whole discussion in October on Mogamulizumab, which is really exciting. And we're also going to be doing a Facebook Live on Brentuximab vedotin. So those are the two newest therapies that we have in our toolbox. So we want to be able to bring you a discussion about those specifically. And next month we'll have Erin Koop, who's a nurse practitioner in the cutaneous lymphoma practice out at City of Hope, who will be joining us for August. And gosh, Mike, what else am I forgetting? I'm sure a lot of things. We will be coming to North Carolina in September with our one-day program. We'll be in New York City in October with Dr. Larissa Geskin for an evening program, and in the Bay Area, San Francisco Bay Area, with Dr. Yan Kim and a lot of the physicians in November. So lots on the docket, and we'll keep bringing you the Facebook Live interviews, and let us know what you want to talk about, because that will help us to better determine who can join us and what our topics are. And I think we had a few tonight. So, and I'm sure we'll have other reasons to bring Dr. DeSimone back to join us. So thank you again, Dr. DeSimone. And thank you, everyone. Have a great rest of your evening and your week and July. Enjoy summer if you're joining us from the Northern Hemisphere. And have a really, really great night. So good night, everyone. And we'll talk to you next month. Bye.